Good afternoon and welcome all the delegates. This is Ankana, the assigned moderator from IJCP Group. We are fortunate enough to get supported by the doctors. Thank you all the doctors for taking out time to join us today. I am taking this opportunity to welcome today's master doctor, none other than the keynote speaker, Dr. Ratan Jha sir. Sir is MD, DM, DNB, DTCD, FISN. He is the senior nephrologist and transplant physician at Care Hospital, Hyderabad. Now, with the help of Sir and his wonderful insights, we will be taking a close look on today's topic, that is, chronic kidney disease is a growing health concern, and managing its progression is crucial for improving patient outcomes. Join us for an insightful webinar on retarding the progression of CKD in recent times, where we will explore all the latest strategies, advancements, and evidence-based practices for slowing CKD progression. Now, without any further delays, I would like to hand over the session to you. Kindly proceed with your topic. Over to you.
Good evening, friends. Today's talk is on retarding the progression of chronic kidney disease in recent times. One has to realize that this is the bread and butter of the nephrologists who are practicing managing a difficult problem of kidney disease, which is usually not curable, but it can be controlled with the options which are already in place. Patients who are not getting an optimal care are likely to go to end-stage renal failure in a short time, and for many, the occurrence of dialysis requiring quite costly number of patients despite the governmental support. And hence, it is very important that we understand how to slow down the kidney disease progression with the scientific therapies which are available and with the evidence-based practice. So my talk is going to cover the various aspects of chronic kidney disease, starting from how do we define to the slowing down the kidney progression, which formula we use in the recent times because the formulas have changed. What is the natural history of kidney disease to understand the therapy that we are giving is really making a difference or not? There are recent KDIGO 2024 guidelines which are given takeaways like for those who may not be nephrologists but want to treat patients to slow down the disease progression. Chronic kidney disease intervention which must be instituted in patients of kidney disease. What are the other kind of approaches which looks at the molecular mechanism of kidney disease progression, like oxidative stress busters and anti-inflammatory measures? What are the top 10 commandments for kidney disease which will be applicable to not only to control the kidney disease but also to slow down the progression if we're able to achieve the goals? And the last thing is that KDIGO 2024 guidelines about the managing patients, the 10 points to remember when you are practicing to manage such patients. Topic that chronic kidney disease is a common disease which affects roughly 15% of population in India. That is, 1 out of 8 Indians are having a chronic kidney disease, though the prevalence has been reported to vary in the different parts of the world, with the average prevalence of 10% of population having kidney disease of some severity or a severe severity. CKD has been ranked as the 12th major cause of death and 17th cause of disability, which is going to change because these are the old records, old reports. The commonest cause of chronic kidney disease throughout the world requiring dialysis, and approximately 20 to 40% of diabetic patients will develop diabetic kidney disease, which will require a renal replacement therapy if they survive the cardiovascular events. In Indian scenario, the prevalence of chronic kidney that we talked about is roughly 15%, with hypertension contributing to 20% of CKD and diabetes 30% of CKD. 50% of patients who come to nephrologists are coming too late when the GFR is below 15 ml per minute, which is considered as CKD stage 5, when they have nothing to prevent it, that is to be treated. So we need to see the patient early to slow down the kidney disease progression. So the term CKD is usually applied to the abnormality of kidney structure or function which is lasting for more than 3 months and which should have a health implication. By the term health implication, it means that a person who has donated a kidney to a kith and kin may have only one kidney, and that is not considered as a kind of chronic kidney disease unless it has a health implication in the form of hypertension or any other form. So CKD is defined as abnormality of structure or function. By the term structure, we mean that any kind of change disparity in size or shape or the content can be considered as a structural defect like a polycystic kidney disease where the kidney function creatinine may be normal but still it is a chronic kidney disease because cysts are there. So structural change are usually demonstrated by an ultrasound or an X-ray abdomen or CT scan or MRI or a functional change which is usually characterized by a change in the blood biochemistry in the form of change in the urea, creatinine, ABG electrolytes. And it is supported by the urine abnormality in the form of proteinuria, hematuria, and a pathological abnormality if we biopsy a patient and kidney biopsy findings. So we need to have a combination of the structural, functional, and imaging changes to make a diagnosis of chronic kidney disease, which will be lasting for more than 3 months. These days, it is said that when you make a diagnosis of chronic kidney disease, you should apply a formula of CAG, that is the cause of chronic kidney disease, the cause and the amount of albuminuria, that is A of the CAG, and G is for the GFR category, that is what is the degree of renal dysfunction. So we talk about this the chronic kidney disease under the three kind of acronyms: CKD with diabetes, albuminuria, and GFR say 15. That is the way it has to be reported. GFR is the preferred way over serum creatinine to assess the renal functions in chronic kidney disease, and hence we do not talk about creatinine alone. We talk always in the context of creatinine, the GFR. So this is a classification which has to be always applied when we see a patient of chronic kidney disease, the KDIGO classification, where the GFR is quantified from G1 to G5 based on the level of GFR. G1 is a GFR above 90, G2 is GFR between 90 to 60, G3 is between 60 to 30, which has been further classified into 3 and 3B, and G4 is GFR between 30 to 15, and G5 is below 15, which is called kidney failure. So the CKD G5 is considered a kidney failure, which was earlier not clearly defined, and we used to talk about chronic renal failure, which used to give a feeling that patient is having a kidney failure, which is detrimental to health. So now we talk about chronic renal failure as a stage of CKD when the GFR is below 15. And when we talk about this GFR, the G kind of classification, the CAG, A also has to be factored. That is, A is A1, A2, and A3 based on albuminuria less than 30, between 30 to 300, and above 300. And this combination will give an idea about the risk to the patient in the follow-up. And this is called the heat map study. A person who has lesser albuminuria and a preserved GFR has very low risk of dying because of cardiovascular events or other events which can increase the risk of death. But those who are having a higher degree of albuminuria or lower GFR, that is shown as a kind of red kind of zone, which that means the person is at very high risk of death and has to be closely monitored so that he can be managed without any kind of difficulty in the follow-up. So, when we talk about a chronic kidney disease, the etiologies of chronic kidney disease is always grouped under the categories of glomerular disease, tubular disease, or vascular disease, or genetic and cystic disease. These are the broad groups of chronic kidney disease. The kidney has only three compartments, and it can be because of the glomerular involvement, tubular involvement, or vascular involvement. And cyst and congenital diseases are involving all the compartments, and it is really a genetic disease. Like we talked about ADPKD, that is adult dominant polycystic kidney disease, Alport syndrome, where it is a the congenital disease with deafness as well as kidney disease with glomerular disease, Fabry's disease. These are the categories of CKD one has to understand when we talk about the cause of CKD. The commonest cause of CKD throughout the world is diabetes, hypertension, and after that the immunological disorders like SLE, infection, etc. So the KDIGO to 2024 has talked about 10 takeaways For the nephrologist as well as the other physician who are evaluating patients of chronic kidney disease, in this slide, that is any person, how do we define that person has chronic kidney disease? It is based on the persistence of GFR low below, persistence of kidney abnormality beyond 3 months, and the cause has to be always mentioned as what is the cause of CKD. C, G, the GFR, that is G1 to G5, and A is the albumin category A1, A2, A3. So CKD has to be always defined with the cause, GFR, and the albuminuria. Second takeaway for people to remember that when we see a patient with chronic kidney disease, we need to distinguish it from the acute kidney disease, which could be on the top of it or which can mimic like chronic kidney disease, and that is based on the past records, imaging, and other lab reports. So we should be very clear if that person has a CKD that is beyond 3 months or AKD, which is a kidney disease lasting less than 3 months. When we talk about taking care of patients of CKD, it is to be understood that this is a lifespan kind of management. That is, the whole spectrum of the patient's life has to be monitored, and that approaches could be different for child, for adults, and for the elderly. And one has to also factor those aspects before trying to talk about the long-term management. Diagnosis of CKD in older adults is a point which has to be always understood that many patients who are elderly may have a GFR on the lower side. It may not be 100 ml, but if it is above 60 and if they have no other kind of risk factors, this may be normal part of aging. And to make a diagnosis of CKD in older adults, the cutoff values of 60 ml has been taken as the important threshold to advise the patient that they have a chronic kidney disease in the absence of albuminuria, hypertension, or diabetes. The fifth point that one has to understand is that we should have an accurate assessment of GFR, because GFR can be vitiated because of the loss of muscle mass in people who have become wasted, like in a patient of liver disease and a patient of malignancy. And in that situation, we should not depend on the creatinine based GFR, and we may have to employ creatinine plus cystatin based GFR. That is the fifth point that is takeaway for 2024. We need to have a good lab, because accuracy and reliability of creatinine will determine what kind of GFR we are getting and what kind of assessment or what kind of suggestion we have to make. We need to use a validated GFR estimating equation, and at this point of time, we have CKD EPI 2021 equation, which has been validated for creatinine as well as for cystatin. Point of care test is also important, and people who are living in remote spaces like village, it has been mentioned that we should have a kind of urinary dipstick testing to take care of the albuminuria quantification, as well as the creatinine, which is a dry chemistry, which is now available in various parts of the world where people can have a kind of creatinine without lab. We need to use a validated risk assessment tool to say that what is the risk of patient dying, like we talked about the heat map study of the KDIGO classification, or the cardiac events formulas which should be appropriate for patient of kidney disease. And timing assessment and re-evaluation is very important, that how frequently we need to call based on the heat map study that we discussed in the previous slide. So these are the 10 takeaways on 2024 in the context of chronic kidney disease management for all the people who take care of such patients. So when we talk about the GFR estimation, we are now having a tool which is a kind of calculator, which can be downloaded freely from the net, the National Kidney Foundation calculator, where we have different kind of formulas which can be used. So this was an older formula, CKD EPI equation 2009, where the race was included, and where we have to only put serum creatinine, age, gender, and race to get a GFR. But the recent formula has excluded the race concept, and we are now talking about CKD EPI creatinine equation, where only we have to enter the patient's creatinine, the sex, and the age, and we get the values, whatever is the GFR. So we can use creatinine based equation, or even a cystatin based equation, or an equation which contains both creatinine and cystatin to get the right kind of GFR in patients where the creatinine may be fallacious. For children, we use the revised Schwartz formula, which is available on the National Kidney Foundation website, foundation for this app, and which is can be downloaded on smartphone to immediately calculate the GFR based on the creatinine or cystatin. One has to understand that we need not ask the lab to give a GFR from the lab. If we have the calculator, we can calculate it, because that will mean additional burden to the patient, because many of the labs are uh, adding extra cost if GFR is asked, though they are not doing anything extra, only it is being calculated. So we need to be familiar that we do not require a GFR from the lab, and we can calculate the GFR based on these equations. This is a very important slide for everybody to understand that how accurate is the GFR was a thing which has been already discussed in the literature. At this point of time, CKD EPI based equation is said to be the most preferred equation, and National Kidney Foundation recommends that in adults we use CKD EPI equation, though in children we use Schwarz formula. And cystatin based formulas are only recommended when we find the GFR is borderline, and where the muscle mass has altered because of the wasting line patient liver disease or cachexia, where we need to have a combination of creatinine and cystatin based equation. It has been recommended that it is preferable if cystatin C is available to use a combination kind of approach to make a correct characterization of patient of chronic kidney disease. So this is a kind of map to show that what has happened over the last maybe three decades. That in 1990 there are various parts of the country you see that the prevalence of CKD was quite less, but from 1990 to 2017 there are many pockets of the red zone, which like Punjab, Tamil Nadu, Kerala, West Bengal, where the prevalence of CKD has been reported to be the highest. And it could be because of the better facilities to make a diagnosis in these areas. But overall, the prevalence of kidney disease in the country, which has increased, is to the tune of 15%. And it has been reported that the commonest cause of chronic kidney disease way back one decade back was diabetic kidney disease, the commonest cause, followed by hypertension and chronic glomerulonephritis. And even the recent time in 2021, it was reported in India that diabetic kidney disease still continues to be the commonest cause of kidney disease, followed by hypertension, which is usually a kind of disease which is because of drugs into there, which we do not know, and it could be because of the environmental toxins. Other causes like chronic glomerulonephritis, hypertension, atherosclerosis, polycystic kidney disease constitute the remaining cause. So, in India, even in the recent time, the diabetic kidney disease is the commonest cause of kidney disease, which is getting treated under the nephrologist. When we talk about the protective strategies to in the context of chronic kidney disease, we mean that the strategy which can impact the kidney disease in the context of albuminuria, in the context of change of EGFR, in the context of mortality risk, renal mortality, cardiovascular mortality, or infection related mortality. So these are the areas which can be targeted when we are trying to treat a patient of kidney disease. And any therapy which reduces albuminuria by more than 30% in the persistent way, or is going to have a benefit in reducing the slope of EGFR decline, and by that we may be able to reduce the cardiac as well as the renal risk, because cardiorenal syndrome is a common kind of association in patients of chronic kidney disease. Infection is always a problem in the patient of kidney disease because of the altered immunogenicity, or because of deficient kind of immune response in patient of chronic kidney disease. We know that CKD is a kind of state where a person is immunocompromised, is not able to kind of launch a good kind of host response to take care of infection, and they are higher risk of infection-related mortality as well. So it is said that when we are trying to slow down the disease progression with drugs, the end conclusion is that all patients should have at least once a year kind of GFR and assessment, albuminuria assessment, and one has to do this quite more often in patients who are having a more rapid kind of changes in the GFR or albuminuria. So at least a minimum once a year kind of checkup is required in patients who are predisposed to have a progressive diabetic kidney disease. It is important to remember that many diseases have different kind of courses in the follow-up, and diabetic kidney disease is one of the worst disease which has got a rapidly worsening course if they are associated with albuminuria, poor control of diabetes, or a bad control of blood pressure. Chronic glomerulonephritis with proteinuria also has a faster deterioration. Chronic intestinal nephritis, in contrast, are slow progressor. That is a disease of kidney disease where the albuminuria is not much, but kidney is abnormal because of either infection, toxin, or dominant polycystic kidney disease. One of the slowest increasing disease, and it is said that patients with ADPKD, whose kidney size is increasing and who have ultrasound-based evidence of more than 16 centimeter, may benefit with newer therapies like the tolvaptan, which may not be appropriate for other cancer disease. So, the diabetic kidney disease has a kind of fall of GFR of more than 5 to 10 ml per year once the disease goes into stage 3 and beyond. In contrast, chronic glomerulonephritis has a kind of fall of GFR which varies depending on the etiology from 3 to 5 ml. It is said that age-related decline in GFR after 30 years is roughly 1 ml per year. Any therapy which reduces the fall in GFR to below 5 could be a good therapy. We target with drugs and diet to slow down the disease progression 2 ml per year. Fast progressors are defined as kidney disease is a disease where the fall of GFR is more than 5, and if you are giving RAS blockade, the fall of GFR is roughly 5 ml, which can be slowed down to 2 to 3 ml when you add an SGLT2 inhibitor. So we have to understand what is the kind of reduction of GFR which happens when you are trying to give the kind of scientific therapies in this kind of situation of progressive disease. Every disease has a different kind of profile of fall of GFR. So to reiterate, the rapid progression of chronic kidney disease is a situation where the GFR fall is more than 5 ml per year. So we need to wait for 1 year to get an idea whether the person is having a rapid fall of GFR in a patient who has slowed disease progression. But a patient who changes his CKD category from say stage 3 to stage 4 is also considered a rapid progression, which may happen in less than a year's time. And any fall of GFR from 25% from baseline is also considered as a rapid fall of GFR. But for all practical purposes, in a chronic kidney disease, we try to bank upon the fall of GFR over 1 year time of more than 5 ml. The way we monitor the GFR decline or a CKD progression is we look at the creatinine change, and it is said that to have a creatinine change with any intervention, it requires roughly 4 months to get an idea about that. So we require 6 consecutive creatinine report to be clear about the impact of the therapy. So we require roughly 24 months or 2 years to get an idea about a real change with the therapy that we are given to slow down the disease progression. It is important that when you find there is an accelerated rate of GFR decline, it means that there is some acute factor, and this can be utilized to assess the efficacy of intervention as well. So what is shown in this slide, which is a slide from a very important paradigm HF trial, where the blue lines are for those who are having no diabetes, and red lines for those who are having diabetes with ACE inhibitor or the use of sacubitril valsartan. You see that how the creatinine slope has changed over next 3 years, and based on this slope we decide whether the therapy has made a difference or not. Like in this slide, what is very clear is the top line is person who are getting enalapril, and the second line is one who is getting sacubitril valsartans. So what we see clearly is that person who have received this sacubitril valsartan have done better, but even in diabetes as well as non-diabetes. So based on this change in the GFR over time, we decide whether the measures which we have taken to reduce the kidney disease progression has got better or not. Is there any reversible factor, any acute factor in a situation when the person comes with a kind of higher creatinine is very important to understand, because acute factors are reversible. These are the treatable factors. And any patient who comes with azotemia, the fiasco factor should be looked at. The term fiasco factor will mean that is there any fluid deficiency, infection, a for activity of disease or arterial venous abnormality of hypertension, renal vein thrombosis. As for substance abuse like contrast, ACE inhibitor, NSAID, amino glycoside, consuming toxic materials like native medication, indigenous medicine, alcohol and drugs, and O for obstruction. So this is just an acronym to remember that these are the factors which can suddenly change the profile of kidney disease from chronic to the acute deterioration. And when we find the patient has come with sudden change in the kidney function, these are the things which need to be looked at and treated, and that can make a difference, and the patient can get better. So when a patient of chronic kidney has no fiasco factors, that is, there is no fluid overload or deficiency, no infection, no activity of disease, no substance abuse, no consumption of any abnormal drugs, or no obstruction, practically the kidney disease is not going to get better, and it may slowly evolve over time to go towards the downhill course of end-stage renal failure. So one has to understand that these are the things which every physician should be able to identify in a patient of chronic kidney disease. So this is just to show you what happens over time in a patient of chronic kidney disease. The top line is showing that this is a natural fall of GFR, and that can be addressed by the appropriate drug therapy, which Nafaz will discuss in subsequent slide. But a patient can have immediate fall of GFR if they have used, say, NSAID for gouty pain, or contrast for coronary catheterization, or infection treated with amino glycoside, or use of diuretics in high dose with ACE inhibitor producing hypertension, where the fall of GFR is very rapid in contrast to the fall of GFR which is slow. And hence it is very important that the patients who are being taken care by primary care physician are able to recognize these kind of changes which can happen with the interventions or with the other associated features, which can be modified and which can be treated to make the line going from down to the top line that we talked about. So situation in animals as well. Protective therapies have the greatest impact if it is initiated before the plasma creatinine concentration exceeds 1.5 to 2 milligram, or before the GFR has gone below 60 ml. That is to say that if we are late in starting, then the benefits are less. The progression in chronic kidney disease may be due, at least in part, to the secondary factors that are unrelated to the activity of initial disease, and this can also be targeted. That we discuss in the subsequent slide. The major factors uh, which have been analyzed and understood, which ultimately leads to the progression of chronic kidney disease, is the intraglomerular hypertension, which is different from the systemic hypertension that we so that you, so this is a thing which has to be always understood, and this has to be targeted with the appropriate drug therapy. And when we have intraglomerular hypertension, even the intraglomerular hypertrophy happens, which leads to ultimately glomerular sclerosis. The additional factor that we talked about, which may be operative in a patient with kidney disease, are systemic hypertension, which is different from the intraglomerular hypertension, hyperlipidemia, which could be associated with chronic inflammation of the CKD, metabolic acidosis, and tubular disease, which are the factors which can lead to a slowly progressive disease, even in a situation of basic control of the factors which led to the kidney disease to begin with. So this is a cartoon to make everybody understand that when we are having a normal kind of kidney, the top line, six yellow kind of glomerulus are working all right. So this means the quantum of glomerulus which is filtering is okay and GFR is normal. But as the glomerulus becomes damaged, like the four glomerulus that is shown in the middle slide, only two glomerulus are working properly and they become hypertrophied. And because of the extra work, they suffer from intraglomerular hypertension. Over time, they also get damaged, and that is called glomerular sclerosis. So the concept of intraglomerular this this hypertension is basically an hyperfiltration injury in the remaining glomerulus, which ultimately suffers from the glomerular sclerosis, the long course. And this is going to happen, and we can only uh, be able to reduce the kind of this interglomerular hypertension by appropriate measures and postpone the CKD by different interventions. We cannot totally prevent it. So this hyperfiltration injury is common to all forms of chronic kidney disease, and the quantum or the rate of the hyperfiltration depends on many other factors that we talked about, secondary factors, which has to be also taken care of when you're trying to patient of chronic kidney disease to slow down the disease progression. So this is just to give an idea that what can happen if you are trying to treat or prevent the kidney disease early. So this is a kind of hypothetical transformation of a recent IMPASS CKD trial, where it was calculated that if you start the patients with appropriate drug therapy when the GFR is 85, with use of drugs like RAS blockade and SGLT2 inhibitor like empagliflozin at a GFR of 85, we can postpone the kidney disease to reach an end-stage renal failure by 25 years. But if we delay it, then the fall of GFR, the degree of protection will be less. Like if we start a patient when GFR is 60 ml, that is stage 3 disease, the protection is for 20 years. If we start at GFR 30, the protection is for 10 years. And if we start at GFR of say 20, the protection is for 2 years. That is 2 years of postponement of dialysis. So earlier we start, longer is the chances that we can postpone the need for dialysis. Is the kind of message which came from the analysis of IMPASS CKD trial, and that we follow. It is said that if we are able to use these drugs in association with MRAs, which are like finerenone, we can have an additional 6 years of life in most of the patients of diabetic kidney disease. And now we have many other new drugs available, like which may be a part of therapy in future, like zibotentan and other drugs, which may postpone the disease further and make it to the tune of 1 ml per minute, which is a natural kind of fall. So the strategies for retarding the natural progression of kidney disease is shown in the slide. The common strategies are using drugs which reduces the interglomerular pressure like RAS blockers, SGLT2 inhibitors. Drugs like metabolic acidosis therapy is not a drug which reduces interglomerular pressure, but it has an additional effect on the chronic tubulointerstitial compartment of kidney contribution in the CKD progression. And tolvaptan is a drug which is used usually in situation of ADPKD in an appropriate situation when the kidney size is more than 16, or the other additional criteria to use the drug tolvaptan. So drugs therapy for practical purposes for most of the patients category is the use of RAS blocker, SGLT2 inhibitors, and in the recent times for diabetic patient, finerenone. Metabolic acidosis is to be targeted appropriately, and tolvaptan can be used as a drug for ADPKD. In the diet, it has been suggested that in a right patient, protein restriction to the tune of 0.6 to 8 gram is going to have a beneficial effect. But by the term right patient, we mean that person should not be malnourished. Insult prevention is a very important concept for slowing the disease progression, and the cardiorenal insult, particularly the catheterization, the cardiac catheterization, use of contrast can be a kind of insult, but it has to be done when person requires it for acute coronary syndrome. But we need to space the kind of interventions to prevent the kidney disease progression. Autoimmune flares, particularly SLE, we need to use the appropriate immunosuppression to prevent that, because any flare produces a kind of damage which has got a residual damage persisting even after the flare settles. Vaccination, because infections have been known to trigger many kinds of autoimmune disease as well as insults to the kidney, heart, lung, and which may have a deleterious effect on the GFR. And avoiding toxins. By the term avoiding toxin, we mean that the so-called herbal toxins and the drug toxins which may have a kind of impact on the kidney function. The other category of drugs like prebiotics, probiotics, and protein-bound uremic toxin molecules are a kind of add-on therapies at the moment and still not recommended as a standard of therapy to slow down disease progression. Anti-inflammatory drugs and oxidative stress busters are also utilized when we have used the classical standard drug therapies in patients who are having chronic kidney disease. we find that the first three concepts, that using the appropriate drugs, the RAS blocker, SGLT2 inhibitors, metabolic acidosis, protein restriction, many times this gets overlooked and we are basing our therapies to pre-probiotics and anti-inflammatory, which is not the right way to take care of such patients. So the treatment targets when we talk about CKD disease progression retardation is treating the albuminuria with the right drug combination so that albumina come down, treating the uncontrolled hypertension, and in patients who are having severe proteinuria, BP should be always below 130/80, and treating the hyperglycemia with the appropriate drugs at the right time. Many other risk factors that have been identified which may have an impact on the CKD progression are environmental exposure to smoking, uh, to diabetes which is not controlled, abnormal glucose concentration, metabolic syndrome, that is obesity related problems which may have an impact on kidney progression, analgesic abuse because of any factor, and other factors like alcohol use, which may not be associated with increased risk but may have other kind of association which can make the patient more vulnerable to kidney insult. So these things also has to be looked at when we are trying to treat a patient with CKD. This is a very important slide to deliver the point that if a person's blood pressure is 160 by 100 with whatever drug therapy, the fall of GFR is more than 10 ml. And if we reduce from 160 by 100 to say 130 by 85, the fall of GFR can go down to 2 to 3 ml. That is to say that loading the blood pressure in CKD is important to slow down the disease progression with the appropriate drug. And in this context, the RAS blocker is one of the drugs which has to be always incorporated in the therapy, and there is no such a restriction to use or not to use the RAS blocker with the creatinine above 2, but one has to use it with caution to prevent the risk of hyperkalemia. So blood pressure lowering is a therapy which has to be always focused, and this is one of the potential factors which can slow down the disease progression in most of the patients. Secondary factors that we always look at in a patient of chronic kidney disease are the interglomerular hypertension, hypertrophy, and at this point of time, the drugs which can act at that level is basically the RAS blockers and SGLT2 inhibitors. Some of the calcium channel blockers of the recent times are also having an effect on the interglomerular hypertension. Retention of hyperphosphatemia can have an impact on CKD progression. Increased prostaglandin synthesis can also have an impact on CKD progression. Hyperlipidemia, particularly in the nephrotic syndrome, has been linked to CKD progression, and drug therapies to target this thing may not have been able to reduce the fall of GFR, but may have a better effect in protecting the patient from the cardiac risk. Metabolic acidosis is to be targeted. Proteinuria is to be targeted with the right drug combination. Tubular interstitial disease related inflammation can be treated with proper drug therapy which can take care of acidosis as well as anemia. Uremic toxicity removal by the appropriate drugs which may have an impact on this can be utilized, and in this context the pre-probiotic combination have been claimed to have that kind of benefit. And iron therapy can have an impact on the CKD progression, and iron overload should be avoided. Is there any situation where the AHR ARB in the chronic kidney disease should not be used? That is the question that is put in the slide. The answer is that every person should receive AHR ARB when the patient has chronic kidney disease, because AHR ARB extends life of patient with chronic kidney disease. They slow down the progression of kidney disease despite early rise in serum creatinine. This RAS blockade delays the progression of dialysis regardless of when they are begun. The rise in creatinine associated with RAS blockade is not necessarily a bad thing, but it needs to be interpreted properly and patient have to be explained so that they do not discontinue the drug. So the first answer is RAS blockade should be a part of any therapy in CKD because it extends the life of the patient. So ASI and ARB are considered standard of care in all patients with CKD, irrespective of hypertension, no hypertension, because that can be utilized in most of the patients. The optimum renal protective dose of ASI and ARBs are different from the BP reduction, which are the common ways the cardiologist and physician prescribe the drug. BP reduction the maximal dose of BP control may not be the appropriate dose for renal protection, and it has been reported the higher supramaximal dose exhibits better renal protection than the lower conventional dose. And it is reported that the RAS bucket of 1.5 to 2 times the hypertensive dose is the renoprotective dose by money et al. And we utilize this kind of dose in patients who can tolerate it. The RAS blockade 1.5 to 2 means the dose should be twice the dose which is recommended for hypertension. For example, the telmisartan dose, the maximum dose for hypertension is 80. For proteinuria reduction and kidney protection, the dose could be as high as 160 milligram, provided the person can tolerate it. That is, by the term tolerate means BP should not become very low, neither person should develop hyperkalemia. When we are using a supramaximal dose, we need to tell the patient that during the sick day time, the drug has to be discontinued so that they do not develop hypertension and AKI. So this is the same thing which has been reported from Chennai, that the progression of chronic kidney disease with renin blocker is seen in people who have received the highest dose of RAS blockade. And the best dose for most of the patients is 1.5 to 2 times. So in their study, they said that this drug significantly offers better renal protection in all varieties of CKD. The GFR fall of 1.5 ml was noted in people who have received the appropriate high dose versus 6 ml in those who have not received the drug. The RAS blockade score at which maximum benefit was achieved in DKD was 3 times. That is, you require 3 times the antihypertensive dose. For CGN 1.5 times and for CIN 1 time. That is, if you're using a drug like enalapril, the antihypertensive dose maximum dose is 40 milligram. But in diabetic kidney disease, the dose as high as 120 milligram can be used with the maximum benefit if it is not producing a hypotension. Aggressive RAS blockade in all CKD patients is to be done to postpone the end stage renal disease, and for in general 2 times the dose of any RAS blocker is utilized in an appropriate patient to slow down the disease progression. The benefits of continuing RAS inhibition in advanced CKD has already been reported in literature, and STOP ACE trial has also, which is published in 2023, also has talked about that those who discontinue the drug do not benefit to a large extent, and they may have a higher incidence of cardiovascular event and death, and hence the drug can be continued even in, let's say, a kidney disease if we are able to monitor it, and when it is required either for cardiac or renal risks. Two novel compounds for hyperkalemia has come, which can take care of the risk of hyperkalemia when you are using the RAS blocker in, let's say, kidney disease, like patidamar and zirconium salicylate. The drug which we are having at the moment is sodium polystyrene sulfonate, and when we have this sodium zirconium salicylate ZS9, probably we will not have to worry for hyperkalemia when using a RAS blocker in, let's say, a kidney disease. It has also been suggested that we need to employ the treatment for metabolic acidosis by giving the right kind of sodium bicarbonate therapy to target the bicarbonate level to 24 to 26, which has been found to be a cheaper therapy which slows down the CKD progression. And in this context, we have 2 or 3 types of approaches to treat acidosis. First strategy is to use sodium bicarbonate or sodium or potassium citrate if the potassium is all right. The second therapy is to reduce the dietary kind of load by reducing the kind of non-vegetarian intake, including fruits and plant-based protein. And third therapy is the newer drug, which is not still available, the Veverimer, which can take care of metabolic acidosis without producing the over the sodium overload risk, which may be associated with sodium bicarbonate therapy. We say that metabolic acidosis is not severe when the metabolic acidosis is in the range of 12 to 22, which is the common thing in patients of chronic renal failure. Acute or severe metabolic acidosis is defined, which produces Kussmaul's kind of respiration when the bicarbonate is below 12 milligram per liter. So Veverimer is a drug which is orally administered and is excreted in feces, and this is a kind of non-sodium based therapy, and it's well tolerated. And whenever it is available, this will replace the sodium bicarbonate therapy for taking care of metabolic acidosis. In absence of that, we still use sodium bicarbonate as a drug with a target bicarbonate of 24 milligram per liter. Diabetes is a situation where the pump, pipe, and filters get affected. By the term pump, we mean heart failure, cardiovascular events, or acute coronary syndrome. Pipe means atherosclerotic risk, and filter means the kidney risk. So patients of diabetes have the effect on all the three kind of zones: the pump, pipe, and filter. And SGLT2 inhibitor, which is a new kind of drug class, which is now a kind of backbone of all CKD therapies, is to be employed to take care of the damage that is happening because of other diabetes or non-diabetic situation of kidney disease, to reduce the risk of heart failure, kidney disease progression, and atherosclerotic risk. This is a slide to make us understand that why we talk about protein restriction, because it decreases the load on the remaining nephron, because we talked about nephron suffers from hyperfiltration injury, and if the load is reduced, the hyperfiltration will reduce. And this may have other kinds of benefit, like it improves insulin resistance, it reduces oxidative stress, it reduces proteinuria, and it has an impact on the parathyroid hormone. It has an effect on, like an angiotensin converting enzyme, that it reduces intracranial pressure with a reduction in proteinuria. It reduces the risk of need for dialysis by 40%, and it improves lipid profile. So there are many kinds of things which happen with protein restriction. And simple statement is that if we are a vegetarian, our diet is already protein restricted, and most of the Indians will not require any additional protein restriction for CKD progression. So Indian diet is predominantly vegetarian. Vegetarian diet is having a low biological value. It generates less nitrogen. It is lipid friendly. It has got a better ratio of omega fatty acids. That omega 3 to 6 is better. Has more fibers, and the deficiency of one can be this taken care by the supplementation of other, like rice and pulse combination can take care of lysine deficiency and methionine deficiency, and that is how the Indian diet is a good diet for patients who are having chronic kidney disease when the diet is vegetarian. When a patient of oxidative stress is looked at the metabolic level, patients of chronic kidney disease is always in inflammation, and the inflammation in the CKD is because of various reactive oxygen species molecules, which could be a kind of nitrogen oxide, or it could be a kind of HOC3, that is chlorinated oxidative molecule, or classical oxidative stress molecule OH minus, or carbonyl stress. So there are different types of reactive oxygen species which are produced by this metabolism of various substances and various dietary items, which once accumulate ultimately leads to kind of damage to the cell membrane, the lipid peroxidation and DNA damage, and that is how the cell suffers from apoptosis and death. So drugs which may be acting at the level of this molecular level of reactive oxygen species can be of help theoretically in a patient of chronic kidney disease, which could be a supplemental therapy when we have taken care of the basic therapies which are advocated. So the simplest link that we can target when we see a patient of kidney disease is that CKD is a situation where there are a lot of uremic and non-uremic toxins which accumulate, which ultimately increases the oxidative stress. This oxidative stress that we talked about, the reactive oxygen species can have lead to endothelial dysfunction, which endothelial dysfunction can lead to a kind of inflammation and cytokine-driven process. The cytokines can lead to liver activity. You can get lot of substances which are said to be a kind of which ultimately leads to a kind of inflammation, which leads to malnutrition, atherosclerosis, anemia. This is called a Maya syndrome, malnutrition, atherosclerosis, and inflammation. And this, because of this acute phase reactor APR that we talked about, the liver produces, like CRP and other things, the person develops a kind of anemia because of inadequate erythropoietin action, that is erythropoietin resistance, loss of residual renal function, and death. So we have to understand that they are linked. That toxin produces stress, oxidative produces endothelial dysfunction, it produces inflammation, inflammation produces liver producing acute phase reactants, which leads to kind of Maya syndrome with loss of residual function and death because of the infection risk. So this is a very complex process, and we have tried to look at these links by different drug molecules, which we'll discuss in the subsequent slide. So there are many agents which have been said to be operative at different levels. Oxidative cysteine and taurine, where we use it with nefosate, pentoxyphylline, or thiazolidine diones, allopurinol, magistral acetate, coenzyme Q, vitamin A, symbiotics, probiotics, flavonoid, resveratrol, fish oil. These are the so many kind of molecules which are acting at different levels of oxidative stress, but none of them in isolation have been recommended to be used in a patient with chronic kidney disease to slow down the disease progression. This could be an add-on therapies once we have done the basic management of reducing the intraglomerular pressure and treating the metabolic acidosis with the right drug combination. This is an important slide to understand that we are not talking about the microbiome, the gut kidney axis, because we know that kidney disease patients are increased risk of risk biosis, and many kind of pre-processed foods are available in the market. There are different names which act at the level of gut and is claimed to reduce the inflammation and toxins, and thereby having an impact on CKD progression. This is a slide to make one understand that what can happen because of infection. This is a patient of lupus nephritis who received a vaccination because of the continued use of immunosuppressant and developed serious pneumonia, which was because of streptococcus pneumoniae, which was detected by the PCR-based investigation, and patient became dialysis dependent and now is on dialysis. So even the infection which can be prevented by vaccination, if it is done, may have an impact in preventing the need for dialysis in many patients early, and this could be also a part of a CKD prevention by appropriate vaccination. So the 10-point care which can slow down the disease progression in patient CKD is shown in the slide. The BP should be best controlled. 130 by 80 is the target, with 125 by 75 tolerated if patient is protein. We need to use the supraphysiological dose of ACE-ARB 2 to 2.5 times to get the best benefit. Protein restriction can be employed, which is not required because most of the patients are already restricted in protein. Probiotics and prebiotics can be added, but that is an add-on therapy. Serum bicarbonate therapy has to be targeted because that has got impact on CKD progression. Anemia with iron in the right range, hemoglobin between 11 to 12 will be the best way to take care of anemia, and it has been reported in the experimental labs that oral erythropoietin, that the decidustat, which is now available, may have a beneficial effect on CKD progression. So treating anemia may have an impact in the kidney progression, but it has not been quantified, and it has been having a kind of impact on the general health, preventing the cardiorenal risk. Anemia as a target for CKD progression has not been found to be effective, but certain reports are suggesting that if we treat the anemia well with the newer drugs, this may be feasible. Mineral and bone metabolism is very important, and it has to keep the calcium phosphate, alkaline phosphate in the right range with the appropriate drug combination along with vitamin D supplement. And dyslipidemia is very important to be targeted because most of the patients die of the cardiac events, cardiorenal risk, and it has to be in the right range with the right drug combination to be started quite early. Vascular access may be a kind of thing which has to be planned because the disease is progressive, and doing dialysis without the infection risk from the central catheter could be another way to prolong the patient's life. And hence, vascular access creation is very important at right time, and GFR when it falls to 20, access to be planned. Vaccination, the four vaccines that we always should give is hepatitis B, influenza, pneumonia two types, and if person is above 50 years of age, using the drug Shingrix vaccine, which is for herpes zoster prevention, should be employed, and which we are employing for optimal care as a patient. Counseling, psychological, socio-economic, family counseling, anti-smoke counseling, renal replacement therapy planning is also a part of care which may prolong the life of such patients when the kidney becomes uh, end stage where dialysis is required. So the final 10 takeaways for nephrologists on the management of people with CKD, uh, which has been given in 2024, is that we should have a comprehensive strategy for treating a disease. There's nothing called one way approach, and this should be a lifestyle change, the healthy diet, physical activity, stop tobacco products, reduce salt intake, sleep well for 6 to 8 hours, adopting a healthy and diverse diet. That is, there's nothing called a fixed kidney diet. One should prefer a plant-based food over animal foods. Avoid ultra-processed foods because these contain higher amount of phosphorus, potassium, and salt. Individualized BP control that we talked about, the BP control, the best control is in the range of 125 systolic to 75 diastolic in young people. 130 by 80 is still acceptable in patients who are proteinuria, but those who cannot tolerate, or elderly people, 140 by 90 is also a target which can be accepted. A less intensive strategy may be required in failed patients. Renin angiotensin system blockade by RAS inhibition SGLT2 inhibitor should be employed in all the patients unless there are serious contraindications, and this is to be used in patients who are albuminuria with or without diabetes. Patients who have heart failure must get SGLT2 inhibitor irrespective of albuminuria, because many patients have a heart failure with preserved ejection fraction, and heart failure is because of anemia and hypertension, and may not be because of the coronary artery disease. So RAS blocker SGLT2 inhibitor should be always utilized adequately in patients CKD. Acute change in EGFR should be properly interpreted, and person who is receiving RAS blocker SGLT2 inhibitor, this should be always remember that there is a dip in the GFR because of rising creatinine, and this is a hemodynamic effect and doesn't warrant drug withdrawal unless the GFR has fallen above 30%. Cardiovascular disease management is appropriate, and this is to be focused with the use of statins in all, and maybe the antiplatelets for secondary prevention if the patient has a higher risk or patient has a kind of calcium scoring in the CT scan in the cardiac was more than 100. So these are the patients who should be getting an antiplatelet in addition to the statins in the right dose. Thorough medication review is very important when we see a patient GFR is changing, because this may have a kind of impact on the long term, because drugs whose GFR is falling. For example, a patient who is getting gabapentin for neuropathic pain, the dose has to be reduced, otherwise the person will become drowsy, or person can become comatose because of the drug therapy, and many times patient gets investigated in the line of stroke, but it has a drug side effect. Discontinuation of RAS blocker, the SGLT2 inhibitor, is recommended in acute situation, or sick day rules have to be employed, but it should again be restarted because many times people forget to restart the drug. Symptomatic control of CKD is very important, and many symptoms are related to GI tract like anorexia, vomiting, constipation, which has to be appropriately treated. And in patients who are too old or elderly, advanced layer planning has to be done so that do not the attendant do not get bored from the psychological distress of taking care of their kith and kin. And these are the 10 top takeaways for nephrologists managing patients of CKD in 2024 adequately. So we should use SGLT2 inhibitor and RAS blocker because both of them are acting at different level. RAS blocker is conceptually acting at the level of efferent arteriole, and SGLT2 is acting at the level of efferent arterioles. In both combination reduces the intracranial pressure, and that leads to reduced proteinuria and kind of reduced risk of glomerulosclerosis. In future, as a nephrologist, a physician, we will soon face the happy dilemma of choosing the third line of nephroprotection after a RAS blocker and SGLT2 inhibitor. Among the five contenders, like the mineralocorticoid receptor antagonist like findinone, aldosterone synthase inhibitors, GLP-1 receptor analog like semaglutide, sparsentan, which is a dual endothelin receptor antagonist, as well as renin antagonist, and zibotentan. So all these drugs are probably going to compete as a third line drug after the RAS blockade and SGLT2 inhibitors. And at this point of time, MRA is a third line this contender in diabetic patient, because that is the only approved indication of this drug. HIF in that is the hypoxia initial factor, which is a basis of using the oral EPO. Uh, in experimental animals were found to be renoprotective, and whether treating anemia with these drugs may have a kind of kidney impact is a thing which is going to be clear in the future reports. Till then, we need to remember that We need to frozenate the patients who are having kidney disease, at least that every person should be in SGLT inhibitor after RAS blockade and hope for the best. So change is the only constant in our life, and what we see the change in our communication, transport, and we need to change our ideas based on the available evidence. And that is all I wanted to share with you. Thank you.
Am I audible to you, sir? Am I audible to you?
Yes.
Okay. Thank you so much, sir, for this comprehensive talk. And this is a very beautiful and informative PPT that you have presented. Sir, we have received few questions. Can I put them across? The first question
Yes.
is, sir, diabetic nephropathy, how to manage when sugar is not under control, even after medical treatment due to lumbar canal stenosis and polyneuropathy physical activity is poor.
There's no situation where the diabetes will not get controlled with the use of insulin in the right combination. As you said, the patient is having lumbar canal stenosis with many pain. Person is not able to do exercise. The physical activity is limited, and that may be contributed to poor diabetic control. In that situation, the approach for treating diabetes is basically using the right combination of oral as well as injectable drugs for diabetic control. And for pain, people many times use gabapentin in different along with antidepressant to control the pain part, etc. There are various kinds of cocktail of vitamin B therapies are there, which is given to patients for pain relief. Diabetes by itself, if not properly controlled, gives a lot of kind of polyneuropathic pain. So we try to treat the patient for control of diabetes. That is, we always need to remember that A, B, C, D is approach in all patients with diabetic kidney. A for hemoglobin A1C, B for blood pressure control, C for cholesterol control, D for diet and other measures that has to be there. So we have to see that all the things are target. And if hemoglobin A1C is not in the target, then we have to use insulin right dose, and we have to ask the expert, like the endocrinologist, why the diabetes is not getting controlled. Many times the diet may not be appropriate. Exercise, you said that patient is having lumbar canal stenosis, so may not be able to do the exercise. That is the common thing in people who are obese, that they are not able to do exercise. They can only manage their day-to-day activities. In that situation, we have to employ the dietary restriction for losing weight. We have to employ the insulin in case, and we are not having many kinds of approaches which reduces weight loss, which produces weight loss, like semaglutide injection is available in the foreign countries. We are using semaglutide. Oral semaglutide is available for diabetic control. So we have different combinations. So this is a difficult patient where we have to take help of the expert to control the diabetes. Without control of diabetes, neither pain will get better, neither kidney or not kidney disease can get protected. So glycemic control is very important in the early stage, and BP control is important in the later stage. What simplistic, but nothing is less important in any stage. So we have to have A, B, C, D approach to take care of A1C, blood pressure control, cholesterol control, and diet management.
Okay, moving to the next question, that is, sir, my only right kidney is functioning, which has moderate HDN. No resonance found in complete investigation done by PGI Chandigarh. I work as a school teacher, stand and speak 3 to 4 hours in a day. Usually my serum CR level is 1.6 and 1.7, but if I take 3 to 4 days rest, it goes down almost normal 1.2 or 1.3. I take metoprolol, AM Telma, clonidine tablets. What to do, sir?
So it's a very practical question that has been asked. That person is having a only single functioning kidney with a GFR which is low. Creatinine 1.6, 1.7 is GFR is low. He says 3 CKD that is there. He's getting telmisartan or something which is a RAS blocker. He's getting the right drugs. He can use an SGLT2 inhibitor as well. SGLT2 inhibitor, there are many drugs available in the market. One has to contact his primary care physician and get this drug added to the kidney disease to slow down the disease progression. He has a low GFR, and this can be the kidney disease can be taken care for many years if we start the therapy at this stage. One kidney is sufficient to keep the patient in good health for long. if we are able to take care of that ABCD concept. If you're not diabetic, A is not required, B is required, C is required, D is required. And RAS blockade and SGLT2 inhibitor, first and second line pillars of therapy, must be employed. Based on what he said, he was getting only RAS blockade in the form of telmisartan. So that is one drug he's getting. He's not getting drugs for cholesterol management, because a patient of cardiac, renal patient has a very high risk of cardiac disease. So cardiac syndrome is there, which is silent. Most of the patients of kidney disease die of heart attack and other things before they reach end-stage renal failure. So we have to have a comprehensive approach. The diet should be all right. That D part, C cholesterol should be all right, and B is the blood pressure should be best controlled with the right drug combination. We may have to follow very closely. And the change in creatinine value is what he said could be because of fluid intake. Maybe fluid, when he's taking less fluid, creatinine is slightly higher. When he takes enough fluid, creatinine becomes better exit. But definitely he has a low nephron mass because only one kidney is there. We know that each kidney we have 10 lakh nephrons. So is there only one kidney we have left with only 10 lakh nephrons? And the 10 lakh nephron has to work for 20 lakh nephrons. It is suffering from hyperfiltration injury. So this can only be addressed by reducing the pressure in the kidney also with the drugs that we talked about, the RAS blockade as well as the SGLT2 inhibitor, for which the patient has to talk to his doctor and get the therapy changed.
Okay. The next question is, how should hypertension be managed in CKD patients to prevent further kidney damage?
The hypotension is less common in CKD patients. More common is hypertension. But there are few patients who keeps on having a kind of salt resting kidney disease where the blood pressure is on the lower side, etc. So they do well. There are patients who have lower blood pressure. Most of the time, they have a lower kind of CKD progression compared to those who have high blood pressure. But if the patient pressure has become low, that can produce an insult to kidney. And in that situation, one has to understand why the BP has gone down. Commonest reason for hypertension in a patient of CKD is either because of loose motion or diarrhea, or sometimes infection, any kind of infection, like dengue or any other kind of infection like chikungunya, which is the influenza. Many types of infection can produce sudden hypotension because of systemic inflammation. So infection and the GI upsets probably are the common causes of low blood pressure in most of CKD. And if it is GI upset, you have to give IV fluid. If it is because of infection, you have to treat infection and stop the PP tablet at that point of time. That is called the sick day rules. That during the sick time, you have to stop the antihypertensive drug and reinitiate once the sick factor has gone away.
Okay, moving to the next question, that is, one has asked, DAPA versus EMPA.
Yes. Which one to choose? The question is which one to choose, DAPA versus MPAR. Both the drugs have been found to have a kind of beneficial impact on the kidney disease. Dapagliflozin, DAPA CKD trial is there, which has been found to be quite useful for kidney, and the MPAR CKD trial also is there, which is quite useful for kidney disease. So both the drugs are having equal impact. Regardless of benefit, different trials have given different information, but we feel that as a drug class, both the drugs have the equal kind of benefit for the cardio-renal protection. So one can use the drug based on the cost factor. At this point of time, because dapagliflozin, many biosimilar people are using that, and empagliflozin, which is still patented drug, the drug is a bit costly, and hence few people are using it. But we have evidences for both. I use empagliflozin in patients who have both serious heart disease and kidney disease, and use dapagliflozin in patients who have only kidney disease as a major manifestation.
Okay, moving to the next question, that is, my posterior urethral valve PUV surgery in 1998 and BNI surgery in 2013. CKD stage 4, creatinine levels 3.2, polycythemia 2. What to do,
Hmm.
sir?
So now this is a which is slowly increasing. It's gone to stage 3B. Posterior rectal valve basic factors we have already taken care of. So one has to understand that even if the basic disease has been taken care of, the damage which has happened is producing more damage. That is, that whatever nephrons are left in the kidney which are functioning, they are overworking, etc. So there is no way we can slow down the kidney disease progression by the same therapy that we talked about, taking care of blood pressure with the RAS blockade or reduce the interglomar pressure, taking care of the pressure by SGLT2 inhibitors if there are no infection. Dietary modification, the person taking a high protein diet which increases the interglomar pressure can be reduced. And many other methods are there, like many things are there which a physician who is taking care of them can understand. And vaccination to prevent infection, because every small kind of insult will put a kind of pressure on the kidney. And this kidney, what the reporter said, is going to progress over time. And if a person doesn't die of heart disease, he is going to require a renal replacement therapy in future. So we have to look at the heart factor also. Cholesterol has to be looked at. So we have to look at the total picture of the patient to prevent the heart disease to produce any problem, and take care of kidney disease as long as possible without dialysis before the patient is transplant at an appropriate stage.
Okay, taking the last question for today's session, that is, sir, can a person take sodium bicarbonate if serum creatinine is normal?
No, that is just like dietary supplementation. Actually, we do not give therapies to protect the kidney, etc. By like that. The sodium bicarbonate therapy. Why should you take sodium bicarbonate therapy? That means a salt overload is there. We normally take soda in the food, etc. In the cooking, many people use many things, etc. So that is just a drug supplement. But sodium bicarbonate can be taken in a normal person. There's nothing because whatever you do not need it kidney will reject it. So kidney is a very important biochemical organ, etc., which will retain things which are required by the body and reject it when it is not required. So if your kidney is functioning well, taking these things are not going to make any difference.
Thank you so much, sir, for answering all the queries of our doctors. And I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, sir, for your valuable insights and for your time for being with us at our platform and sharing
Thank
such
you.
valuable insights to our doctors. With all your permission, can we end the live here?
Yes, thank you.
Okay, sir. Thank you.